Ankle fractures. Seems pretty straightforward, doesn't it? You trip, twist your ankle, maybe hear a pop, and suddenly, well, walking's off the cards. But what if I told you that what feels like a simple accident is actually one of the most common and surprisingly complex orthopedic injuries out there? We're talking about roughly 187 out of every 100,000 adults facing this kind of challenge each year. And a seemingly minor twist, can escalate into a really serious medical situation. It might need major surgery, and there's a real risk of long-term arthritis that can, well, change your life. Welcome to the deep dive. Our mission here is really to cut through the noise, to take a whole stack of articles, research papers, expert notes, and just unpack them for you. We're going to pull out those crucial knowledge nuggets, the surprising facts, the essential insights, basically giving you a shortcut to being truly well informed on quite complex topics. Think of it as us sifting through all that dense material together, pulling out what really matters. Today, we're diving deep into the world of ankle fractures. We'll explore how something so common can actually be so incredibly intricate. And guiding us through this material, drawing from this wealth of information, sources like Stat Pearls, the AAOS, OrthoBullets, leading orthopedic journals, is our expert who has spent countless hours grappling with these complex cases.
It's good to be here, ready to hopefully demystify an injury that affects so many people, yet holds these surprising layers of complexity once you look closely at the sources.
Excellent. So let's jump straight in, shall we? Let's set the scene with a few high-impact questions that really get to the heart of it all. We just mentioned that a simple twist can lead to serious injuries. Looking at the sources, how does that seemingly minor event actually unleash such significant damage?
It's a great question, actually, and it really highlights the energy involved. A twist isn't just a gentle motion, it's a force application. The sources show how rotational forces, or even axial forces, transmitted through the ankle joint, even from something quite low energy like stepping awkwardly off a curb, can be powerful enough to snap bone. And critically, at the same time, tear the incredibly strong ligaments that hold the ankle together. It's that combination, you see, the bone and soft tissue damage, that makes them complex.
Okay, right. So the force really matters. Does that mean every ankle fracture gets treated the same way then, regardless of how it happened?
Oh, absolutely not, no. And the sources are very, very clear on this. The treatment strategy is dictated not just by the broken bone itself, but crucially by the stability of the ankle joints after the injury. A simple crack, let's say, that leaves the joint stable is managed very differently from a fracture, even a small one, that allows the main ankle bone, the talus, to shift out of place. It's definitely a spectrum. It ranges from perhaps just a walking boot all the way through to complex surgical reconstruction.
And we noted that some patients face particular challenges, especially those with other health conditions like diabetes. What makes those cases so different? Often more difficult, you said.
Yes, and this is such a critical point, highlighted strongly in the sources. Diabetes, particularly when it's associated with nerve damage neuropathy or poor circulation, it introduces a whole cascade of risks. Healing is compromised, both the bone and the soft tissues. Patients might lose that protective sensation, meaning they can unknowingly put stress on a healing fracture.
Right, they just don't feel it.
Exactly, and this drastically increases the risk of infection. We're talking potentially up to a 20% risk in some groups, compared to maybe 1–2% non-diabetics. It's huge. On top of that, bone quality can be poor, making surgical fixation, getting screws to hold, quite difficult. And then there's that devastating risk of progressive joint destruction called Charcot-arthropathy. It really changes everything about how you approach their care and the potential long-term outlook.
Those are really significant challenges. Okay, let's unpack all of this properly, starting right at the foundation. The anatomy of the ankle. The sources describe it as a hinged synovial joint. Can you guide us through the essential structure?
Of course, yeah. Think of the ankle as, well, a finely tuned machine. It's designed for movement primarily in one plane that's moving your foot up and down. We call that dorsiflexion and plantar flexion. At its core, you've got three main bones. The distal part of the tibia, that's the large shin bone, the distal part of the fibula, the smaller bone running alongside it, and the talus. The talus is a sort of wedge-shaped bone, and it's nestled precisely between the tibia and fibula, sitting right on top of the heel bone.
And those bony knobs we can all feel on either side of our ankle, those are the malleoli, right?
Exactly right, yes.
Yeah.
And these are crucial projections that kind of cup the talus. On the inside, you've got the medial malleolus, which is the end of the tibia. On the outside, the lateral malleolus, that's the end of the fibula. And significantly, at the back of the tibia, there's the posterior malleolus. These three bony pillars, along with the smooth articular surfaces where they meet the talus, form what's called the ankle mortise.
The mortise.
Yes, think of it like a very precise socket, or maybe a vise, holding that talus securely in place. Its integrity, its shape, is absolutely vital for normal ankle function.
It sounds like those bony structures alone, though, wouldn't be enough to provide full stability. The sources really emphasize the importance of key soft tissues. What are these critical ligaments actually doing?
You're spot on. The ligaments are like incredibly strong ropes or straps, holding those bones together and, crucially, preventing excessive movement. First, there's the ankle syndesmosis. Now, this isn't a typical joint. It's a really tough fibrous connection holding the distal tibia and fibula tightly together. It maintains the width and integrity of that mortise. The sources list key parts like the anterior and posterior inferior tibiofibular ligaments and the interosseous ligament a bit higher up. Damage here to the syndesmosis is often what people call a high ankle sprain. And it's crucial because it disrupts the stability of the mortise itself.
And what about the ligaments on the sides?
Yes. So on the medial, or the inner side, you have the very robust deltoid ligament. It's a sort of fan-shaped structure that originates from the medial malleolus and spreads out to attach to multiple bones in the foot. It's the primary restraint against the ankle rolling too far outwards, what we call excessive eversion.
Right.
Then on the lateral, or the outer side, is the lateral ligament complex. This is made up of 3 distinct ligaments, all arising from the lateral malleolus. The anterior talofibular ligament, ATFL, the calcaneofibular ligament, CFL, and the posterior talofibular ligament, PTFL. This complex resists the ankle rolling too far inwards, excessive inversion. The ATFL is the one that's most commonly sprained, in a typical ankle sprain.
So when someone says they've just sprained their ankle, they've likely damaged these ligaments. A fracture means the bone's broken, but the sources seem to show these injuries are often intertwined. Is that right?
Precisely, yes. The forces that cause a ligament to tear can also be strong enough to pull a piece of bone off where the ligament attaches. That's called an avulsion fracture. Or the same force can cause a ligament to rupture and break a bone somewhere else in that ankle ring structure we'll talk about. And a significant ligament injury can actually render a fracture unstable, even if the bony break itself seems quite minor. This is why you absolutely cannot look at the bone in isolation. You have to consider the soft tissues as well.
The sources also briefly touch upon the nerves and blood vessels supplying the ankle. It just adds another layer of complexity, doesn't it?
It absolutely does, yes. The ankle and foot receive nerve supply from branches of the tibial and peroneal nerves that's essential for sensation and muscle control, obviously. Blood supply comes from the peroneal and tibial arteries. Understanding this is vital when you think about potential complications like nerve damage during the injury or perhaps during surgery, or healing issues due to poor blood flow, which becomes a major concern in patients with conditions like peripheral vascular disease or, as we mentioned, diabetes.
Okay, that foundational anatomy gives us a really clear picture of what can actually break and tear. Now, how and why do these injuries occur? And who is statistically most affected? Let's look at the etiology and epidemiology from the sources.
Right. The causes are varied, and they reflect different energy levels involved. As we touched on, the most common mechanism is probably a twisting injury, often a relatively low energy event, like slipping, tripping, maybe stepping off a curb awkwardly. But higher energy trauma can also cause fractures. Falls from a height, driving the foot up into the leg, or direct crush injuries from things like road traffic accidents or heavy objects falling onto the foot. The sources make it really clear that the amount of energy involved directly impacts the severity of the injury. Higher energy typically means more fragmented bone comminution and more extensive soft tissue damage.
And the numbers are quite striking. That 187 per 100,000 adults annually figure really brings home how common these are. Is there a pattern in who gets them?
There is, yes. There's a clear bimodal distribution highlighted in the sources. We see a peak incidence in younger males, typically aged sort of 15 to 24. This is often associated with sports activities or these higher energy mechanisms. Then there's a second peak in older females, say age 75 to 84. And in this group, even a trivial twist or a simple fall can lead to a fracture, likely due to factors like bone quality, perhaps balance issues, or just general frailty.
And how do the specific fracture types break down in terms of frequency?
Yeah, the sources give us a good picture here. Isolated unimalleolar fractures, that means a break in just one of those 3 malleoli are the most frequent. They make up about 70% of cases. Bimalleolar fractures, so breaks in 2 malleoli, are next at around 20%.
Okay.
Trimalleolar fractures involving all 3 malleoli account for about 7%. Fortunately, open fractures where the bone actually breaks through the skin are less common, around 2%. But of course, they represent a surgical emergency with much higher complication risks.
So even the seemingly simple types are the vast majority, but the complex ones are far from rare. Are there underlying factors that make someone more prone to these injuries or perhaps complicate their healing?
Yes, the sources list several important risk factors. Beyond the age and sex variations we mentioned, depending on the injury type, obesity is a factor simply due to the increased load on the joint. Lifestyle choices like smoking and excessive alcohol consumption are also key risks, particularly because they significantly impair both bone and wound healing, which becomes absolutely crucial during the recovery phase.
It really seems the patient's overall health and habits are almost as relevant as the injury mechanism itself. Let's move into understanding how these injuries unfold mechanically. This leads us to the classification systems clinicians use. The sources introduce this powerful idea of the ankle joint structures forming a ring. Could you explain that concept?
Right, this ring concept is perhaps one of the most fundamental insights from the sources for really understanding ankle fracture patterns. Imagine the ankle mortise formed by the tibia and fibula cupping the talus, along with those strong syndesmosis and deltoid ligaments. Together, they form a protective ring of stability around the talus. Now, because it's a ring structure, when significant force is applied, it's highly likely to break in at least two places.
Ah, right, like bending a wire circle.
Exactly that. It buckles in two spots. This is crucial because it means if you see one fracture on an X-ray, you must actively look for a second injury point. That could be another bone fracture, or it could be a major ligament rupture, like the syndesmosis or the deltoid ligament. Missing that second injury can leave the ankle unstable, even after you've fixed the obvious break. It leads to poor outcomes.
That's a really clear analogy, and this understanding leads to the different ways clinicians classify these fractures then.
Precisely. These systems help describe the injury pattern, understand the stability, and importantly, guide treatment. The anatomical classification is the most basic, just saying which part is broken. Lateral malleolus, medial malleolus, posterior malleolus, or combinations like bimalleolar or trimalleolar. It's descriptive, but it doesn't tell you much about stability or the mechanism.
Then there's the Dennis-Weber system you mentioned.
Yes, the Dennis-Weber classification. This one specifically focuses on the level of the discal fibula fracture relative to that ankle syndesmosis. So type A is a fibula fracture below the syndesmosis. It's often caused by an adduction force pulling inwards, and it's typically stable, often managed without surgery. Type B is a fibula fracture at the level of the syndesmosis. Now, stability here is variable. It depends heavily on whether the syndesmosis itself or the deltoid ligament on the inside is also injured. And type C is a fibula fracture above the syndesmosis. This pattern almost always involves injury to the syndesmosis and often the deltoid ligament as well. This makes it inherently unstable and usually requires surgery. So this system quickly gives you a clue about likely stability and treatment.
And the Lodge-Hansen system, that sounded like it describes the physics of the injury itself.
It does, yes. The Lodge-Hansen classification is based on the position of the foot. Was it supinated, turned inward, or pronated, turned outwards at the moment of injury, and the direction of the force applied, adduction, abduction, or external rotation. What it describes is a specific cumulative sequence of ligament and bone injuries that occur as that force progresses around the ankle.
And one of these sequences is the most common.
Yes, the supination external rotation, SER mechanism. This accounts for about 60% of all ankle fractures. The sources detailed this step-by-step sequence. It usually starts with a tear of the anterior inferior tibiofibular ligament that's part of the syndesmosis. Then it progresses to a spiral fracture of the distal fibula. As the force continues rotating outwards, it can then tear the posterior inferior tibiofibular ligament or cause a fracture of the posterior malleolus. And finally, it can cause either a fracture of the medial malleolus on the inside or a rupture of the deltoid ligament.
Wow. Seeing that whole progression from just a simple twisting motion really underscores how that energy systematically disrupts the ankle ring. It's quite something.
It is. It shows the complexity.
Are there other distinct types of fractures mentioned in the sources that maybe don't fit neatly into these main classification patterns?
Yes, absolutely. The sources highlight a few important ones to be aware of. A Maisonneuve injury is caused by a pronation external rotation mechanism. It results in a fracture high up in the proximal fibula near the knee, coupled with a syndesmosis disruption and often a medial injury, either deltoid tear or medial malleolus fracture. You absolutely have to examine and x-ray the whole leg.
Right. Easy to miss otherwise.
Very easy. Then there's a pylon fracture, which is completely different. It's an axial load injury, like falling from a significant height. The talus is driven straight up into the weight-bearing surface of the tibia, the tibial plafond, causing severe combination and articular damage. Much more complex. And finally, a Bosworth fracture dislocation. This is rare, but critical to recognize. It's where the fibula dislocates behind the tibia and gets trapped there. It makes it irreducible without surgery.
Yeah.
So these distinct types need specific recognition and quite different management strategies.
That gives us a really comprehensive view of how these injuries are structured and how they occur. What happens when someone with a suspected ankle fracture actually arrives at the hospital? How do healthcare providers go about assessing and diagnosing the injury?
Well, the initial assessment is absolutely paramount, and the sources outline a very clear approach. Firstly, if it's a patient with multiple injuries, perhaps from a major trauma, the priority is always life first. The ATLF primary survey airway, breathing, circulation takes absolute precedence. The ankle injury is assessed thoroughly only after any life-threatening issues are completely ruled out or managed.
And focusing on the injured limb itself, what's the process there?
Right. The assessment of the injured ankle begins immediately, and the sources cannot stress this enough. A meticulous neurovascular assessment is absolutely crucial, and it must be performed before and after any attempt to move, reduce, or splint the ankle.
Okay, so what does that involve? Checking.
It means checking the color and temperature of the foot. Is it pink and warm or pale and cold? Feeling for pulses, like the dorsalis pedis on top of the foot and the posterior tibial behind the medial malleolus. Sometimes you need a Doppler ultrasound if pulses are hard to feel. And testing nerve function, checking sensation and movement in the foot and toes.
And a pale, cold foot is
A medical emergency.
Yeah.
It signals critical loss of blood flow, vascular compromise. Any severe deformity causing this must be urgently reduced, manipulated back into a better position to restore circulation.
And the condition of the soft tissues, the skin and swelling, that also influences decisions.
Hugely, yes. The condition of the skin envelope around the ankle is a major factor, particularly for surgical timing. Is there significant swelling? Is the skin tented, tightly stretched over a displaced bone fragment? That's worrying because it can lead to skin breakdown and effectively turn a closed fracture into an open one. Open fractures, of course, where bone is exposed, are surgical emergencies due to the high infection risk. Often, if the swelling is severe but the skin isn't immediately threatened, surgery might actually be delayed a few days. Waiting allows the swelling to subside, which generally reduces wound healing complications after the operation.
And you mentioned checking the entire leg.
Essential, yes. As we discussed with that Maisonneuve injury, you must physically examine and, if there's any tenderness higher up or the mechanism suggests it, get x-rays of the entire length of the tibia and fibula. You don't want to miss that high fibula fracture.
Clinicians often use a specific tool to help decide if x-rays are even needed in the first place, don't they? The Ottawa ankle rules.
That's right. The Ottawa ankle rules. They're a widely validated clinical decision tool detailed in the sources. They're very effective at helping clinicians avoid unnecessary x-rays for patients who come in with ankle pain after an injury. Essentially, the rule says you do need an x-ray if there's pain in the malleolar zone and either bony tenderness at specific points the posterior edge or tip of either the medial or lateral malleolus within 6 centimeters of the tip, or if the patient is unable to bear weight immediately after the injury and cannot take 4 steps in the emergency department.
So if none of those apply.
If none of those apply, the likelihood of a clinically significant fracture is very low, and x-rays are often deemed unnecessary, saving resources and radiation exposure.
Okay, so if x-rays are needed, what are the standard views used to get the full picture?
The standard initial imaging involves 3 plane radiographs, or x-rays. You get an AP view, anteroposterior front to back, a lateral view from the side, and crucially, a mortise view. The AP view gives a general look and can show soft tissue swelling. The lateral view is vital for assessing posterior malleolus fractures, seeing if the talus is dislocated backwards or forwards, and checking its overall position under the tibia. The mortise view is arguably the most critical standard view for evaluating ankle fractures properly. It requires internally rotating the foot about 15-20 degrees. This projects the fibula slightly forward, so you get a clear, perpendicular view of the ankle mortise space itself.
And that shows.
This view is essential for assessing the alignment of the talus within the mortise. You look closely at the joint spaces, particularly the medial clear space between the talus and medial malleolus, and the tibiofibular clear space and overlap, which tells you about potential syndesmotic widening or any shift of the talus. Any asymmetry is suspicious. And yes, for suspected Maisonneuve injuries, you need those full-length tibia and fibula views too.
And sometimes those standard static views aren't enough to assess the stability, are they?
Correct. That's where the sources discuss the use of dynamic stress views. These can involve manual stress, where the examiner carefully applies an external rotation force to the foot while the x-ray is taken, or sometimes gravity stress views, where the patient lies on their side and the weight of the foot provides the stress. They're performed if there's a strong suspicion of ligamentous instability, perhaps based on the fracture pattern, even if the static x-rays look reasonably okay.
What might they show?
Well, for example, if the medial clear space on a stress view widens to more than 5 mm, normally it should be less than 4 mm, the sources indicate this is highly predictive of a significant tear of the deep deltoid ligament. These views are invaluable for unmasking instability caused by injuries to the syndesmosis or the deltoid ligament, which might make an otherwise simple-looking fracture pattern functionally unstable and require different treatment.
When are the more advanced imaging techniques like CT or MRI brought into play?
CT scans are generally used when the plain x-rays don't provide enough detail, typically for more complex fracture patterns. They are invaluable for assessing articular surface involvement, seeing exactly how the break goes into the joint surface. They show bony comminution, how many fragments there are, really well, and they provide precise detail for surgical planning, especially for complex posterior malleolus fractures or those pylon fractures involving the tibial plafond. They give you that 3D understanding plain x-rays just can't match.
An MRI.
MRI scans are primarily used when the main question is about soft tissue injuries. So looking for torn ligaments, the deltoid, the lateral complex, or syndesmosis disruption. They're also good for picking up cartilage damage, chondral lesions, or perhaps occult fractures, like stress fractures, that might not be visible on standard x-rays.
And finally, before treatment, distinguishing these fracture types from other things that might look similar is key, isn't it? Because the treatment paths are quite different.
Absolutely vital, yes. The sources list important differential diagnoses. You need to be able to rule out simple ankle sprains, which are ligament damage only. Achilles tendon ruptures, they cause an inability to push the foot down, plantar flex, and often you can feel a gap in the tendon. True pylon fractures, which have a different mechanism and usually much worse articular damage, or even subtalar dislocations, that's the joint below the ankle. A careful clinical examination combined with the right imaging helps make that crucial distinction to guide appropriate management.
Okay, that comprehensive assessment process leads directly to the next critical step, deciding on the treatment. And the sources repeatedly stress that the core goal, the overarching aim, is restoring stability to that ankle mortise. Why is that so incredibly critical for the long term?
This is where the long-term outcome is really determined. It's fundamental. As the sources powerfully state, restoring the ankle mortise alignment and stability is paramount because it directly, significantly impacts the risk of developing post-traumatic arthritis later on. Remember that statistic we mentioned? A mere 1 mm shift of the talus within mortise leads to a staggering 42% decrease in the tibio-adductor contact area.
42%, just from 1 millimeter.
42%, yes. When the load going through the ankle is concentrated onto such a small area of the joint cartilage, it simply wears down much more rapidly. This leads to painful, often debilitating arthritis down the line. So getting the joint back into its precise anatomical alignment and ensuring it stays stable during healing is, according to the evidence, the single most important factor for long-term patient satisfaction and reducing that arthritis risk.
And this ultimate goal of restoring stability is what dictates whether the treatment is non-operative or operative.
Precisely. That's the fundamental principle guiding the decision. Unstable fractures, those where the mortise is disrupted or the talus is shifted, generally require surgery to restore that alignment and provide stability. Whereas truly stable fractures, where the alignment is maintained, can often be managed effectively without surgery.
So let's talk about non-operative treatment first. Who is that suitable for?
Yes, the main indications for non-operative treatment include genuinely stable fractures. For instance, an isolated, non-displaced malleolar fracture where the ankle mortise remains perfectly aligned and stable, perhaps even confirmed on weight-bearing x-rays if the patient can tolerate them. It's also considered for patients who are medically unfit for surgery due to other health problems, or perhaps have severe soft tissue conditions like very poor skin quality or active infection that make surgery too risky, or sometimes if the patient refuses surgery.
And what does non-operative management typically involve?
It usually involves immobilization. This might be in a below-knee cast or often, these days, a removable walking boot, depending on the specific fracture and surgeon preference. Pain control is obviously important, and clear guidance on weight-bearing status, typically non-weight-bearing initially, then gradually progressing as healing occurs over several weeks. The sources also mention the possibility of performing a reduction, manipulating the bones back into place, and then applying a close contact cast as a potential alternative for unstable fractures in frail, elderly, or non-surgical candidates, aiming to achieve at least some degree of stability without an operation, though the outcomes can be less predictable.
Okay. And for the unstable fractures, then, surgery is usually the recommended path.
Correct. Operative treatment, most commonly what we call open reduction internal fixation, or ORIF, is generally indicated for any fracture pattern that results in talar displacement or demonstrates disruption of the ankle mortise stability. So this includes virtually all bimalleolar and trimalleolar fractures, bimalleolar equivalents that's typically a lateral malleolus fracture, combined with a significant deltoid ligament tear, making it unstable like a bimalleolar fracture, posterior malleolus fractures that involve a significant portion of the joint surface, say more than 25%, or have a step-off greater than 2 millimeters according to the sources. Also, those specific types like Maisonneuve or Bosworth injuries, and of course all open fractures.
Is there an ideal time to perform the surgery?
Well, the sources suggest surgery is ideally performed relatively soon, often within the first 24 hours, particularly for fracture dislocations that are difficult to keep reduced in a splint, or if the soft tissues are acutely threatened. However, it's actually very common and often preferred to wait a few days, perhaps 5 to 10 days, for significant soft tissue swelling to decrease before proceeding with ORIF. Waiting allows the skin to recover slightly, making wound closure easier and, crucially, lowering the risk of postoperative wound healing complications, like infection or wound breakdown. So the condition of the soft tissues often dictates the timing, balancing the need for stabilization with the risk of wound problems.
What does the surgery, the ORIF, typically involve? What actually happens?
The goal of ORIF is always to achieve an anatomical reduction, putting each fractured fragment back exactly where it belongs, and then fixing it securely with internal implants. These are usually metal plates, screws, or sometimes wires, designed to hold the bones rigidly in place while they heal, thereby restoring the shape and stability of the bone, and most importantly, the ankle mortise. For the fibula, which is broken in the vast majority of ankle fractures, this might involve placing a plate along the side of the bone secured with screws, or sometimes, particularly if the bone is very fragmented or the quality is poor, an intramedullary nail placed down the center of the bone. Medial malleolus fractures are often fixed with 1 or 2 screws placed across the fracture line, or perhaps tension band wiring if the fracture pattern is suitable. Larger displaced posterior malleolus fragments are typically fixed with screws inserted from back to front, or sometimes a small plate placed on the back. Often this is addressed after the fibula has been stabilized. The key is meticulous reduction and stable fixation of each component to rebuild that crucial socket.
And we briefly mentioned external fixation earlier. What's its role?
Yes, a spanning external fixator. This is typically a temporary device used in really severe situations. For instance, grossly unstable fracture dislocations that simply cannot be maintained adequately with splinting, or in open fractures with significant contamination or soft tissue loss where immediate internal fixation would be too risky. It involves inserting pins into the tibia above the fracture and into bones in the foot, like the calcaneus or metatarsals, and connecting these pins with external bars. This framework crosses, or spans, the ankle joint, holding the limb stable and maintaining general alignment. It essentially buys time until definitive ORIF can be performed later, usually once the soft tissue swelling has dramatically reduced and the wound environment is more favorable. Careful pin placement is crucial to avoid areas where future surgical incisions will need to be made for the ORIF.
You mentioned earlier that syndesmotic injury, the high ankle sprain ligament damage, is common, particularly with certain fracture patterns like Weber C. How is that specific instability addressed surgically?
Yes, syndesmotic injury, that disruption of the tight fibrous connection between the distal tibia and fibula, is indeed common. The sources suggest it's found in over 80% of Weber C fractures and maybe 40–50% of Weber B fractures. It's a key cause of instability. If stress fused before surgery or intraoperative tests performed during the surgery, like the Hook test or Cotton test, where the surgeon physically pulls on the fibula shows syndesmotic instability or widening of the mortise, then it absolutely needs to be stabilized. The sources note that achieving an accurate reduction is critical. Using a specific reduction clamp to compress the fibula back into its groove on the tibia, the incisura, often aligning the fibula with the posterior medial ridge of the tibia, is key to getting it right.
And how is it fixed once it's reduced?
Fixation is typically done with 1 or 2 screws inserted across the tibia and fibula, usually about 2 to 4 centimeters above the joint line, often angled slightly from anterior inferior to posterior superior. These are called syndesmotic screws. Newer suture button devices, which use strong suture looped around buttons on either side of the bones, are also increasingly used. One source actually suggests that these might have lower rates of malreduction or needing further surgery compared to traditional screws, potentially allowing earlier weight bearing, but practice varies. There's still some ongoing discussion and debate in the literature about the optimal fixation method. How many screws? Should they engage 3 or 4 cortices of bone? Should the screws be removed later or left in? Critically, if screws are used, patients are almost always kept strictly non-weight bearing for a significant period, typically 8 to 12 weeks, because the screws themselves are not strong enough to withstand walking forces and can break or loosen. The sources also note potentially worse outcomes if screws that remain intact are not removed later, suggesting they might restrict the natural micromotion of the syndesmosis.
That prolonged non-weight bearing must be a really significant burden during recovery. Let's look now at those special cases you flagged earlier that pose particular challenges, starting with diabetic ankle fractures. The risks sounded quite alarming.
They are, unfortunately. Diabetic patients, especially those with neuropathy nerve damage causing loss of sensation and potentially poor circulation due to peripheral vascular disease, represent a major challenge. The sources highlight these risks extensively. Their underlying ability to heal both bone and soft tissue is often significantly impaired. The neuropathy is a huge factor. They might not feel pain or discomfort that would normally signal a problem, like hardware loosening or excessive pressure inside a cast. This increases the risk of them putting too much load on a fragile repair, leading to failure. This loss of protective sensation is also a key risk factor for that progressive, destructive joint condition known as Charcot-arthropathy. Infection rates, as mentioned, are dramatically higher, potentially 10 to 20 times higher than in non-diabetics. Bone quality can be poor, osteopenia, making screw fixation less reliable. All of this means the stakes are much higher, including, sadly, a significantly increased risk of failure of treatment, chronic wounds, and eventual amputation.
So how does the management strategy adapt to these profoundly increased risks?
Well, management in diabetic patients has to be tailored specifically to mitigate these risks as much as possible. Non-operative treatment of unstable fractures in this population is often unsuccessful, with high rates of losing the reduction and progression to Charcot changes. For surgical management, the sources describe using enhanced or sometimes called supercharged fixation techniques. These are designed to provide much greater rigidity and stability than standard fixation. This might involve using multiple screws across the syndesmosis, often engaging all 4 cortices, quadricortical fixation, even if the syndesmosis doesn't seem overtly injured on X-rays. Using stronger locked plates, sometimes augmenting fixation with wires or pins, or even considering primary surgical fusion arthrodesis of the ankle and potentially the subtalar joints in very severe cases or those deemed at very high risk of Charcot progression.
And weight bearing.
Critically prolonged non-weight bearing is absolutely essential, often for 8 to 12 weeks, sometimes even longer, to protect the fragile healing tissues. And vigilant monitoring for any signs of skin breakdown, ulcers, or infection is paramount throughout the entire, often lengthy recovery period. It requires a very cautious and closely supervised approach.
And pediatric ankle fractures are different again because of the growth plates, the physes.
Entirely different ballgame, yes. In children and adolescents whose bones are still growing, the presence of the physis, or growth plate, that cartilaginous area responsible for longitudinal bone growth, is the defining factor. Around 5% of all childhood fractures occur around the ankle. The standard classification for these is the Salter-Harris system, which describes injuries involving the physis, categorizes them based on how the fracture line interacts with the growth plate, the epiphysis end of the bone, and the metaphysis shaft side of the growth plate. The Ogden classification adds some additional more detailed patterns of growth plate injury. One specific, slightly unusual pattern highlighted in the sources, particularly from a paper in JAO's Global Research and Reviews, involves a less commonly reported injury combination. An Ogden type 7 intraepiphyseal fracture of the distal fibula, often occurring alongside a Salter-Harris type 3 fracture of the distal tibia. This typically results from a supination inversion mechanism rolling the ankle inwards.
Okay, what's unique about that specific Ogden type 7 fibula fracture?
It's unique because the fracture line is entirely within the epiphysis, the very end part of the bone that forms the joint surface. But crucially, it doesn't cross the physis, the growth plate itself. It's an intra-articular fracture, meaning it involves the joint surface, but it's extraphyseal. Now, the associated Salter-Harris type 3 tibial fracture does involve both the growth plate and the joint surface. The specific paper you mentioned noted this particular combination as something of a gap in the published literature and presented case studies illustrating how it presents and can be managed.
And how were those specific cases managed in the paper?
Well, for non-displaced fractures where the bone fragments hadn't shifted significantly, non-operative treatment with simple cast immobilization was successful, as described in one of their cases. However, for displaced fractures, as seen in their other cases, surgery was necessary. For the Salter-Harris III tibial fracture component, achieving an anatomical reduction, getting the joint surface perfectly smooth again, is critical to minimize the risk of premature closure of that part of the growth plate or developing arthritis later. But the paper specifically emphasizes that even for the Ogden type 7 fibular fracture component, despite it not crossing the physis directly achieving an anatomic reduction, is still crucial, just as it is in adult fractures. This is to prevent complications like malunion, healing crooked, altered joint biomechanics, and potential long-term arthritis. In one of their cases, they actually had to perform an open surgery on the fibula because a piece of soft tissue, the periosteum, had flicked into the fracture gap, preventing it from being reduced closed.
So even in children, precisely restoring the anatomy, even for a fibula fracture that might look less significant regarding the growth plate itself, is still vital for long-term joint health. That same principle applies.
Absolutely. The fundamental principle holds true across age groups. Any significant malalignment, any residual step or gap in the joint surface leads to uneven loading of the joint cartilage. Over time, this increases the risk of premature wear and tear, leading to arthritis, regardless of age. The paper really underscores that failing to recognize and adequately reduce this specific combination, particularly paying attention to that type 7 fibula component, differentiates it from simpler ankle injuries in children and is key to achieving good long-term function and minimizing later problems.
This brings us quite naturally to a crucial part of any injury discussion: the potential complications. What are the main issues that can arise after an ankle fracture, even when it's had appropriate treatment?
Yes, unfortunately, complications can occur, and the sources provide a pretty comprehensive list. It's important for patients undergoing treatment to be aware of these possibilities. Some common issues include persistent ankle stiffness and swelling. These can actually last for many months after the initial injury, whether treated surgically or non-surgically, and often require quite extensive physiotherapy to manage. For non-operative treatment specifically, there's always a risk of the fracture redisplacing or dislocating if it wasn't truly stable to begin with, or perhaps developing skin problems like pressure sores or ulceration from the cast or boot if not monitored carefully.
And what about more serious potential outcomes?
Well, there are potential problems with the bone healing itself. This includes delayed union, where the fracture takes much longer than expected to heal, non-union, where it fails to heal completely, or malunion, where it heals but in an incorrect or deformed position. And malunion, as we've stressed, is a major known risk factor for developing post-traumatic arthritis later. Chronic instability of the ankle is another potential long-term issue, and we shouldn't forget the risk of blood clots, DVT or PE, particularly after surgery or during periods of immobilization.
And after surgery, there are procedure-specific risks as well.
Yes, there are inherent risks with any surgery. These include the general risks like infection, which we know is much higher in compromised patients like diabetics or smokers. Wound healing problems can occur, such as dehiscence, where the wound edges open up. Painful scars can sometimes be an issue. There's also the risk of nerve damage during the surgical approach. The superficial peroneal nerve is particularly vulnerable with standard approaches to the lateral fibula, potentially causing numbness or pain on the top of the foot. Vascular injury is rare but possible. And there can be issues specifically related to the hardware, the plates and screws. They can fail, loosen over time, perhaps be placed incorrectly, or become prominent and cause irritation under the skin, sometimes requiring a second operation just to remove them later on. Complex regional pain syndrome, CRPS, a debilitating chronic pain condition, is also a recognized, though less common, potential complication after ankle fracture or surgery.
And that significant long-term issue we've mentioned, repeatedly post-traumatic arthritis, that seems like a major concern.
It is arguably the most significant long-term complication, yes. The sources state it's a major cause of ankle arthritis overall, affecting something like 14% of all ankle fracture patients eventually. It's strongly linked to two main factors: the severity of the initial cartilage damage at the time of injury, which we often can't fully assess or treat, and, critically, any residual malalignment or instability of the ankle joint after healing. Even small amounts of residual displacement or slight angular deformity can lead to abnormal loading patterns across the joint cartilage. Over the years, this causes accelerated wear and tear, ultimately resulting in painful, debilitating arthritis that might eventually require further major surgery, like ankle fusion or potentially ankle replacement down the line. Achieving that perfect anatomical reduction surgically is the best way we currently have to minimize this risk, but it certainly doesn't eliminate it entirely, especially if there was significant cartilage impact damage at the time of the initial injury.
And just revisiting Charcot arthropathy again, specifically in the context of diabetic patients.
Yes, it's worth re-emphasizing that's a really severe progressive complication, pretty much unique to neuropathic patients, most commonly those with diabetes. Because of the impaired sensation and often compromised blood supply, the bones and joints essentially self-destruct and deform under normal mechanical stresses that the patient simply doesn't feel. This leads to profound foot and ankle deformities, areas of very high pressure under the skin that cause chronic ulcerations, and a very high associated risk of deep infection spreading to the bone, which often, tragically, necessitates amputation. It really is a devastating potential consequence of unrecognized or poorly managed neuropathy in the context of an ankle injury or even just minor repetitive trauma.
Given all these potential issues and the complexity, what's the typical prognosis and recovery journey actually like for someone with an ankle fracture?
Well, recovery is quite variable, as you'd expect. It really depends on the initial fracture complexity, the treatment method used, and of course, individual patient factors. The sources generally suggest that stable fractures treated non-operatively tend to have a good prognosis overall, with patients often returning to reasonable function within about 6 to 8 weeks, although, as mentioned, some residual swelling and stiffness can persist for longer. For unstable fractures requiring surgery, the recovery is significantly longer and more involved. Patients are typically non-weight-bearing on the operated leg for a minimum of 6 to 8 weeks, and often longer, particularly if syndesmotic screws were used or if there are concerns about bone quality or healing. Then comes the gradual process of regaining motion, strength, and eventually learning to walk normally again, which takes considerable time and dedicated effort with physiotherapy. Full recovery, meaning getting back to near pre-injury levels of activity, can easily take 6 months to a year. And in some more severe cases, functional limitations or some level of pain or discomfort can unfortunately persist for up to 2 years or even longer.
When can people typically start getting back to their normal activities, like driving or sports?
It's definitely a gradual process. Return to driving, particularly if it's the right ankle involved in braking, is typically delayed until around 9 to 12 weeks post-op, once sufficient strength, control, and reaction time are regained. One source actually mentions specific studies looking at braking reaction time needing to return to normal. Limping can often persist for several months as the muscles around the ankle slowly regain their strength and coordination. High-impact activities in sports invariably take the longest, often requiring 6 to 12 months, sometimes even longer, before a safe return is advisable, depending on the sport and the individual's recovery progress.
Are there factors that predict a better or worse outcome?
Yes, the sources do highlight some factors. Generally, factors associated with a better prognosis include being younger, say under 40, being male, though this varies by fracture type initially, having a lower ASA score, which indicates better overall general health, and crucially, the absence of confounding conditions like diabetes or peripheral vascular disease. Factors associated with worse outcomes tend to include older age, female sex, particularly for the low-energy fractures in the elderly, a higher ASA score, the presence of diabetes or PVD, smoking, significant alcohol use, and perhaps lower educational attainment, which can sometimes impact understanding and adherence to complex recovery protocols. The presence of a medial malleolus fracture component also seems to be associated with slightly worse outcomes in some studies.
The sources also touch on the importance of the wider healthcare team involved in managing these injuries. It's not just the surgeon, is it?
Oh, absolutely not. These injuries, especially the more complex ones resulting from high-energy trauma, often involve a whole trauma team initially in the A&E department. Emergency physicians, radiologists, anesthetists, nursing staff, and the orthopedic surgeons. But the ongoing care and rehabilitation is hugely multidisciplinary. Physical therapists or physiotherapists are absolutely crucial. They guide the entire rehab process, working on restoring range of motion, rebuilding strength, improving balance and proprioception, and managing the progression of weight bearing. Their role cannot be overstated. Case managers or social workers are often involved too, particularly in planning discharge from hospital, ensuring patients have the necessary equipment like crutches or walkers, arranging home support or district nursing if needed, and coordinating follow-up appointments. Effective communication and coordination across this entire team are really vital for optimizing patient outcomes.
And patient education seems absolutely key throughout this potentially long process.
Paramount. Yes. Educating the patient properly on what to expect is essential for managing their journey. This includes setting realistic expectations regarding pain levels, the persistence of swelling, which can genuinely last for months, potential changes in sensation around the ankle or foot, and the overall timeline for recovery, which is often longer than people anticipate. It's crucial they understand why non-weight bearing is important if it's prescribed. It's not just arbitrary. And they need to understand the vital role of physiotherapy in regaining function, flexibility, strength, and eventually a normal gait pattern. Providing clear advice on modifiable risk factors that negatively impact healing, like stopping smoking or reducing alcohol intake, is also a key part of patient education and maximizing their potential for a good outcome.
Before we wrap things up, let's try and pull out some key pearls, those quick, really important takeaways that stand out from the sources.
Okay, a few key points really come to mind. First, in trauma patients, always follow the ATLS primary survey. First life always comes before limb. Second, urgent reduction of significantly displaced fracture dislocations is often necessary, especially if the neurovascular status is compromised or the skin is severely threatened. Third, speaking of which, those neurovascular checks are mandatory before and after any reduction attempt or splint application. Document them clearly. Fourth, use appropriate imaging, including stress views if instability is suspected, to fully define the injury pattern and guide management correctly. Don't undertreat an unstable injury. And finally, perhaps be cautious when interpreting subtle findings on x-rays. Make sure you can confidently distinguish between a true avulsion fracture fragment and a normal anatomical variant, like an accessory ossicle, which can sometimes look similar but requires no treatment.
That's a huge amount of critical information distilled down. So for our listener tuning in, what would you say are the most actionable takeaways from this deep dive into ankle fractures? What should they really remember?
I'd say 3 core actionable takeaways really emerge from all this material we've discussed. First, really understand that an ankle fracture is rarely just a broken bone. It's very often a disruption of that complex stability ring, potentially involving both bone and crucial ligaments like the syndesmosis or deltoid. A thorough assessment, actively looking for all injured structures, is absolutely essential for a proper diagnosis and effective treatment plan. Don't just focus on the obvious break. Second, remember that the long-term outcome, particularly regarding the risk of future arthritis, hinges almost entirely on restoring accurate anatomical alignment and stability to the ankle mortise. Even a seemingly small residual shift significantly increases that risk. This really underscores the importance of appropriate, often surgical treatment when instability is present. Anatomic reduction is key. And third, be acutely aware that patient-specific factors, especially underlying conditions like diabetes with neuropathy, dramatically increase the complexity and the risks associated with ankle fractures. These cases demand highly tailored management strategies, enhanced fixation perhaps, prolonged protection, and extra vigilance throughout the entire healing and recovery process to try and avoid those severe complications.
Those insights really do transform our understanding of what an ankle fracture actually entails. It moves it far beyond just a simple break or inconvenience, doesn't it?
It really does. It's a fascinating interplay of mechanics, biology, and those crucial patient-specific variables.
And finally, drawing from this really detailed deep dive, perhaps a provocative thought for our listener to reflect on as we finish.
Okay, consider this. How fundamentally does the body's own ability to heal itself, and crucially, to perceive danger elements that are often profoundly compromised by seemingly unrelated systemic conditions like nerve damage from diabetes, how does that impact its capacity to recover successfully from straightforward mechanical trauma, like an ankle fracture? The interplay between someone's overall systemic health and their localized injury response, particularly highlighted in devastating cases like Charcot arthropathy, really forces us to think about how fragile our innate protective systems actually are when underlying conditions effectively strip away that crucial sensory feedback and the body's inherent healing capacity. It's quite sobering.
That is a truly insightful and challenging thought to end on. Thank you so much for guiding us through this incredibly intricate and detailed deep dive into ankle fractures.
My pleasure. Happy to share the insights from the sources.
And thank you, our listener, for joining us on the deep dive. If you found this exploration valuable, perhaps consider sharing it with your professional network. It might provide crucial insights for a colleague or someone